Welcome back to the deep dive. Today we are strapping in for a really deep exploration into one of the biggest paradigm shifts in the history of modern medical practice.
We're talking about the principles of minimal access surgery, or MAS.
And we're jumping straight into the dense, but absolutely foundational material from Chapter 10 of the 28th edition of Baily and Love's textbook.
That's right, a real cornerstone text.
Now, for you, the learner, our mission today is really threefold. We're going to extract the core principles, we'll anchor the history, and most importantly, we're going to grapple with the limitations and, the revolutionary solutions that came later.
And the goal is to distill it all down into concepts you can actually remember. Think of this as your ready reckoner, maybe a revision tool before an exam.
Or just the fastest way to really get your head around the practical realities of MAS.
But we have to start with a disclaimer, and this is a crucial one. This deep dive is our interpretation. It's designed for learning, for easier retention.
Yeah, we use analogies, anecdotes.
Exactly. But this is not, and I have to stress this is not a replacement for reading the full textbook. We absolutely encourage you to do that for true mastery. This is more of a shortcut to understanding the why and the how.
Agreed, 100%. So let's establish a foundation. At its core, minimal access surgery. It's a fundamental shift in surgical philosophy. What's the working definition?
It's all about achieving the therapeutic outcome, fixing the problem, but with the absolute minimal somatic and psychological trauma to the patient.
So less damage.
Far less. It means reducing the size of the wound you need to access the problem. It's less disfiguring and just dramatically reduces the trauma compared to conventional open techniques.
Okay, so we're moving from this maximal intervention just for exposure to a precise minimal one. We need an anchor metaphor for this.
I like this one. If traditional open surgery is opening the whole window to fix a leaky pipe deep inside the wall.
Right, a huge hole.
MAS is performing that same complex repair through the keyhole.
And that difference, that keyhole versus the whole window, it fundamentally changes everything for the patient's recovery.
Changes the entire trajectory. And that keyhole didn't just appear overnight. It took, decades for the technology to catch up. Things like reliable light, magnification, video.
Yeah, let's hit those historical milestones because they really show why it took so long. You have these early pioneers literally peering inside the body with rigid scopes and really basic lighting.
It's amazing what they did. The first sparks were way back, 1901. A German surgeon, Georg Kelling, did the first experimental laparoscopic procedure on a dog. He called it cilioscopy.
And that proved the concept of using air, right? Insufflation.
It proved that creating space using gas was feasible. Then, just a decade later, 1910, Hans Jacobaeus performed the first thoracoscopy using a cystoscope of all things.
So the idea of looking inside was there, but the ability to actually operate safely, that was missing for most of the 20th century. What was the main constraint?
The big one was visualization. And, instrument control. They couldn't reliably get a high-quality, stable image onto a screen for the whole team to see.
The surgeon was basically working blind, looking through a monocular eyepiece.
Which is incredibly limiting. And that brings us to the real Big Bang moment.
Yeah.
The event that just ignited MAS adoption everywhere.
This would be 1987.
1987. Philippe Mouret performed the first video laparoscopic cholecystectomy, removing a gallbladder, and he recorded it. The use of a video camera and a monitor, it just fundamentally shifted everything.
It went from being this niche, awkward operation for one person.
A procedure the entire team could manage, could assist with, and crucially could teach.
And that success was seismic. It showed that common high-volume procedures could be done this way.
And then in the mid-90s, it just exploded. It crossed every traditional specialty: GI, gynecology, urology, cardiac, orthopedics, because it serves the patient as a whole. It's about minimizing that systemic stress.
Okay, so let's unpack this wide world of MAS. It's not just one technique. It's a whole spectrum of approaches, right? Based on where you're going and how you get there.
Exactly. And we should start with the most conventional, the insufflation-based techniques.
Which means laparoscopy.
The anchor technique, absolutely. You introduce a rigid endoscope into the peritoneal cavity through a port. And this method relies completely on creating that working space, the pneumoperitoneum.
The working dome, you called it.
Yeah, you use CO2 gas to lift the abdominal wall, creating that dome. It's essential for visualization and just being able to move your instruments around.
So moving up from the abdomen, we get to thoracoscopy, or VTS, video-assisted thoracic surgery. The operating space here is completely different.
Totally different set of challenges. The rigid endoscope goes in through an incision between the ribs, but the major distinguishing factor is the anesthetic requirement. You absolutely need special support.
And that means using double lumen endotracheal tubes. So explain that. Why is the double lumen tube so critical for VATS?
Okay, so in the chest, to operate safely, you need the lung on the side you're working on to be collapsed and still. That gives you a clear view.
You're basically shutting one lung down temporarily.
You're putting one lung to sleep, so to speak, while the double lumen tube lets you keep ventilating the other non-operative lung, so the patient is still fully oxygenated.
And unlike the abdomen, where you have to create space, the thorax is rigid. The rib cage holds the space, so gas isn't always needed.
Precisely. The rib cage does the work. But, and this is an important exception, for really complex procedures like a mediastinal tumor resection, you might use a little bit of low-pressure gas.
How low pressure are we talking?
Like 5 to 8 millimole Hg, much lower than in laparoscopy.
Yeah.
And it's just used to subtly improve the view, maybe help with hemostasis, without completely collapsing that isolated lung.
Okay, so from there, let's move toward the cutting edge. The techniques designed to, reduce the scars even further.
Which takes us to single-incision minimal access surgery, SALS, or sometimes called uniportal surgery.
And the goal here is to get everything camera instruments through one single port.
Usually at the umbilicus, yeah. A multi-channel port.
The big appeal is the scarless result, right? Hidden in the belly button. But the textbook highlights a pretty big technical controversy here. What's the geometric problem SILs creates inside?
The problem is you lose triangulation, and your instruments immediately start clashing.
Explain triangulation.
In conventional laparoscopy, your ports are at different points, so your instruments form a triangle around the target. This gives you good angles for dissection, for retraction.
But in SALs?
They're all parallel.
Yeah.
Coming from the same spot. So the tips are constantly running into each other. Surgeons call it the sword fighting effect. And you have almost no ability to pull tissue in opposite directions. Retraction is a nightmare.
So you might reduce the risk of a port site hernia, but you've just made the actual operation 10 times harder.
Drastically harder. It demands specialized articulated instruments and a much, much steeper learning curve. The aesthetics come at a real cost of internal efficiency.
And that inefficiency, plus the cost of the special instruments, is what's holding it back.
It's what limits its widespread adoption, yes.
Yeah.
Even though some surgeons can do incredible things with it.
Moving past SLS, we get to the truly scar-free ideal. Notes. Natural orifice transliminal endoscopic surgery.
Right. So this is using flexible or rigid scopes that pass through natural body openings.
Yeah.
The GI tract, the bladder, the vagina.
And the aim is to do the whole operation, say an appendectomy, completely inside the abdomen, but with no external cuts at all.
That's the ideal.
It sounds like the absolute pinnacle of this philosophy, but Baily and Love flags a huge, massive obstacle here.
The principal issue, and it's a big one, is the safety and the difficulty of closing the visceral puncture site.
Meaning the hole you made to get in.
Exactly. If you enter the peritoneal cavity through the stomach or the colon, you are deliberately creating a point of massive potential contamination. So the closure of that hole has to be perfect, absolutely structurally sound to prevent leakage, peritonitis, sepsis.
Which must be incredibly hard. The stomach wall has multiple layers.
And you need perfect mucosal healing and a perfect serosal closure, all in a field that's hard to get to. The risk of that major internal contamination just outweighs the cosmetic benefit for most procedures right now.
Okay, so what about approaches that don't even use a pre-existing cavity? Paravisceral endoscopy.
This is all about accessing anatomical planes outside the body's natural cavities, but still using MAS tech. Think retroperitoneoscopy, getting to the kidneys or adrenals from behind the abdominal lining.
Or the extraperitoneal approach for an inguinal hernia repair.
Exactly. So the surgeon is using these videoscopes to navigate spaces that, historically, would have required a very large, deep incision. And the enhanced visualization you get just dramatically improves safety and accuracy.
And finally, in this section, we've got the hybrid models, where surgeons combine different techniques.
We can break this into two types. First is the totally endoscopic hybrid. That's combining, say, a flexible scope inside a lumen and a straight stick laparoscope outside.
Like for managing gallstones in the bile duct?
Perfect example. And these often need specialized hybrid theaters with all the advanced imaging.
And the second type is the bridge for so many surgeons. Hand-assisted laparoscopic surgery, or HALS.
HALS is such a vital concept. It's often called the training wheels for an experienced open surgeon who's transitioning to MAS.
So how does it work?
The surgeon makes a small incision, a mini laparotomy, and inserts their hand or forearm through a special sleeve, all while maintaining the pneumoperitoneum.
Now, some people might see that as an admission of failure. You couldn't do it purely laparoscopically, but it's really a safety bridge, isn't it?
It's absolutely a safety bridge, especially in complex cases. The human hand provides four things that straight instruments just can't replicate.
Okay, what are they?
1, palpation, feeling tumors, nodes. 2, blunt dissection, gently separating tissues. 3, atraumatic organ reflection, safely moving a big organ like the liver. And 4, the most crucial one, immediate finger pressure on a bleeding point.
That last one. The ability to just stick your finger on a bleed must be a huge safety net. It saves so much time fumbling with instruments.
It absolutely does. HKLS can dramatically improve safety and efficiency, especially for big specimens like a colon, where you need an incision for extraction anyway. Now, as new surgeons train entirely in laparoscopic and robotic techniques, we expect to see less HALS, but it's a critical skill to have in your back pocket.
Okay, let's for a check-in. Listener, let's put this into practice. A 70-year-old patient needs a large, complex, inflammatory adrenal mass removed. The surgeon expects severe adhesions, maybe it's stuck to the vena cava. They want the benefits of MAS, but they absolutely need to use their sense of touch to safely separate that tumor. Which hybrid approach is their best initial option, and why?
And the answer has to be HALS, hand-assisted laparoscopic surgery. That ability to feel, to palpate, is a non-negotiable safety feature in that kind of hostile anatomy. If you didn't get that immediately, just rewind and listen again to the benefits of the human hand.
All right, now we get to the core justification for this whole revolution. Reducing surgical trauma. We need to detail exactly how MAS pulls this off compared to a big open operation.
Right, because most of the problems in open surgery come purely from that large wound you need for exposure.
That's the source of everything, isn't it? Infection, chronic pain, hernias, nerve entrapment.
Dehiscence. And that big painful wound restricts movement afterwards, which then compounds all the other risks. Chest infections, blood clots. It's a vicious cycle that MAS just breaks.
And a big part of that is retraction.
A huge part. In open surgery, you're using harsh metal retractors, constant pulling, which causes real tissue damage. Now, contrast that with laparoscopy. The retraction is largely provided by the low-pressure pneumoperitoneum itself.
The cushion of gas. I like that metaphor.
It's a diffuse force, applied gently and evenly over the whole abdominal wall. It's not localized crushing. It's a gentle lift.
And MAS also minimizes exposure to the air. Why is that so important?
2 big reasons. It reduces systemic cooling, so less risk of hypothermia, and it reduces fluid loss from evaporation. And, crucially, you see far fewer post-surgical adhesions.
Because you're not handling the delicate serosal coverings as much.
Exactly. Less handling, less drying out from air exposure. You're also handling the bowel less, which means a much lower risk of that painful adynamic ileus where the gut just temporarily shuts down.
And because of all these benefits, MAS quickly moved into emergency surgery, right?
It did. The advantages just made sense. Things like an omental patch repair for a perforated ulcer or in stable trauma patients for an initial look around without a huge laparotomy.
Okay, let's do a quick summary. Key takeaways on the advantages.
Think of it as a cascade. A smaller wound leads to less infection and hernia risk. That leads to less pain, which means better mobility. You also have less systemic stress from heat and fluid loss. And on top of all that, you get this incredible magnified view of the deep operative field.
But now we have to confront the challenges. Because for all those massive wins, standard straight-stick endoscopic surgery has some really big inherent limitations. And these are the problems that drove the whole robotic revolution.
The first and the most immediate one for any trainee is the 2D challenge. You're operating based on a flat, two-dimensional image of a three-dimensional space. You lose all the visual cues for depth.
All the subtle shadows, the parallax, it's gone.
It's gone. And that loss of depth perception is huge. But it's made even worse by a mechanical problem called the fulcrum effect.
This is the core technical hurdle, right?
Yeah, it is. The long, rigid instrument goes through a fixed point, the port, which acts as a fulcrum. Because it's a rigid lever, when your hand outside the body moves up,
The tip of the instrument inside the body moves down.
it's a complete reversal of your natural hand-eye coordination. You have to fight the mechanics of the tool while trying to interpret a flat image. It creates this massive learning curve. It's incredibly frustrating for novices.
So even a great open surgeon has to basically rewire their brain to get good at this.
They do. And while some non-robotic 3D systems were developed, they didn't solve that mechanical dexterity problem and often gave surgeons headaches or eye strain. They were a poor investment.
Okay, the second big functional loss, tactile feedback, haptics.
In open surgery, your sense of touch is just vital. You feel for nodes, you feel the texture of tissue. With straight sticks, you lose most of that. The feedback is so attenuated by the long shaft.
So you can't feel the tension on a suture or how fragile a piece of tissue is?
Exactly. So surgeons have to find visual substitutes.
And the main one is laparoscopic ultrasound, LUS.
Yes, LUS is used as a visual replacement for palpation. You can use it to see stones in the bile duct that you can't feel, but it requires special skills, special equipment, and it's just not the same as the feedback you get from your own hand.
Let's talk about a major intraoperative stressor, hemostasis, bleeding. What happens when things go wrong endoscopically?
Bleeding is a massive problem because blood absorbs light. Even a small pool of blood can just black out your view from the endoscope.
You're suddenly operating in the dark.
Pretty much. And managing that requires incredible skill and teamwork. You need an assistant who can provide a stable camera view, continuous irrigation, and precise suction all at the same time. The reliance on your assistant is immense.
And if you can't control it quickly with clips or energy devices...
The threshold for conversion has to be very, very low.
Finally, let's talk about the tissue extraction dilemma. You do this whole keyhole procedure, and then you have to get a big specimen out.
It's unavoidable for something like a section of colon or lung. You have to enlarge one of the incisions. But the crucial rule here is about malignancy.
The specimen has to come out whole.
It has to come out whole and inside a protective bag that you put it in while still inside the body. This is to maintain the specimen's integrity for the pathologist.
And the rule against morcellation, breaking it up, is absolute for cancer?
It is, because you disrupt the specimen for staging and you risk implanting cancer cells at the port site. While that risk has been minimized with better technique, the need for an intact specimen is non-negotiable in cancer surgery.
All right, another quick summary, key takeaways on the limitations.
Okay, remember these 6 points. The 2D vision problem, the mechanical fulcrum effect, the loss of tactile feedback, or haptics, the huge difficulty with bleeding in vision, the need to enlarge an incision for big specimens, and that initial, very steep learning curve for the surgeon.
So all those limitations we just detailed, the 2D view, the fulcrum effect, the loss of dexterity, they created this huge market need. And the response was the surgical robot. So let's formally define what that is.
A surgical robot is fundamentally a mechanical device. It performs precise physical tasks, but it does it according to human supervision, or maybe a predefined program. It's a high-tech human-machine interface.
And its whole purpose is to restore what was lost in straight sticks surgery.
Exactly, to restore and even enhance the surgeon's natural dexterity and visualization in that minimally invasive field.
And we can categorize these systems into 2 main types.
The dominant type is the teleoperated master-slave system. This is what everyone thinks of, the Da Vinci platform. The surgeon, the master, sits at a console away from the table, and their hand movements are translated by a computer to control the instruments, the slave, inside the patient.
And this is what proved that remote surgery was even possible.
It did. The Paris-New York cholecystectomy was the ultimate proof of concept, even though true remote surgery is incredibly rare today.
And the second category involves systems that are more autonomous.
These are the active or semi-active systems. An active system, like the old robo-DOC for hip replacements, performs a pre-programmed task with very little human intervention at the time. A semi-active system is more of a collaboration, part pre-programmed, part surgeon-driven.
Okay, so let's trace the family tree of the Da Vinci to see how all these features evolved.
It really starts in 1985 with the PUMA 560, which was used for CT-guided brain biopsies. Super accurate.
But the first big step in the OR was the camera holder.
That was ASOP in 1992, the automated endoscopic system for optimal positioning. It was a voice-controlled robotic camera arm. For the first time, you replace a human assistant's task with a robot that gave the surgeon a perfectly stable, hands-free view.
That alone must have been a huge improvement. But then came ZUS.
ZUS in 1996 was the true ancestor of the master-slave systems. It was a 3-arm system, and it introduced 2 absolute game changers: motion scaling and tremor correction.
And that's what led to the first fully robotic procedure in '98.
And then since 2000, it's been the story of Intuitive Surgical's Da Vinci system. So what are the key features that allowed it to finally conquer the limitations of straight-stick laparoscopy?
Let's break them down. What's the first one?
First and foremost, vision. The 3D high-definition stereoscopic imaging immediately solved the 2D problem. The surgeon gets true depth perception back.
Second, dexterity. This fixed the fulcrum problem.
The maneuverability and dexterity from the endo-wrist instruments is just revolutionary. They're modeled on the human wrist, but better. They have up to 7 degrees of freedom. They can bend and rotate in ways a human wrist just can't. especially in tight spaces like the pelvis or the throat.
And third, the precision features we mentioned, motion scaling and tremor suppression.
This is the genius of the computer in the middle. The system scales down your large hand movements outside the body into tiny, precise movements inside, and at the same time, it filters out your natural physiological tremor.
So our anchor here is that it basically turns a shaky hand into a rock-steady one.
An absolutely steady surgical instrument. The precision is just immense.
And the final feature is less technical, but maybe just as important, ergonomics.
Vastly improved ergonomics. The surgeon is sitting comfortably at a console, not standing hunched over a patient for 6 hours. That reduction in physical stress and fatigue is huge. It could mean fewer errors and a longer career.
But that console is a bit of a double-edged sword, isn't it?
It is a trade-off. The isolation helps with concentration, but it physically separates you from your team at the bedside. You lose all that nonverbal communication.
The subtle nod, the eye contact.
All of it. Which means you need rigorous team training and crystal clear verbal communication. And you need a competent, dedicated bedside assistant who knows what to do in a crisis.
Okay, let's address the elephant in the room that every hospital administrator worries about. The cost.
The cost is the primary disadvantage. It's the source of the whole debate. Robotic surgery is profoundly more expensive than non-robotic alternatives. You have the huge purchase price of the robot itself, and then the very high consumable costs of the specialized single-use instruments.
And this is where we have to be critical. If the tech is so much better, why is it still so hard to prove a significant improvement in clinical outcomes, like mortality, when you compare it to a really skilled, conventional laparoscopic surgeon?
And that is the core challenge for economic justification. While the robot makes complex procedures easier and more reproducible for more surgeons, the data often shows equivalence in things like length of stay or complication rates.
So the justification shifts.
It shifts to things like maybe it reduces the learning curve, or it reduces surgeon fatigue in long cases, which might lead to better outcomes. And of course, it's a huge marketing tool for hospitals.
So we're prioritizing surgeon comfort and reproducibility, but at a much, much higher price point for the healthcare system.
That's the trade-off, and it's enormous. Plus, setting up a program takes time, training, and then you have to share the machine between specialties, which can slow everyone down.
This high cost has, of course, led to new competition. Let's talk about the new systems challenging Da Vinci.
We're now seeing these innovative modular systems designed to cut costs and add flexibility. One is the Versius system. Instead of one massive cart, it uses separate modular arms on their own carts.
Which gives you more freedom in how you set up the room.
More freedom in port placement, yeah. It mimics the human arm more closely.
And another system is trying to bridge the gap between old and new.
That would be the Senhan system. Its focus is on cutting those recurring consumable costs. It uses independent arms, but crucially, it uses reusable, non-wristed instruments that fit into standard laparoscopic trocars.
So that dramatically cuts the per-case cost.
Exactly. It's a strategic move to appeal to surgeons who are already comfortable with straight-stick laparoscopy while still giving them the 3D vision and robotic camera control.
Okay, another check-in question. Imagine you're a hospital administrator. Your surgeons are already great at standard laparoscopy. Which new system, Versius or Senhance, makes the more immediate economic argument based purely on consumable costs and using your existing equipment?
The answer is Senhance. Because it uses reusable non-wristed instruments in standard trocars, it directly attacks that high consumable cost of the Da Vinci. If you didn't get that, focus on the difference between reusable and specialized articulated instruments.
All right, let's move from the tech to the patient. We have to talk about the meticulous planning that is absolutely essential for safe MAS.
Pre-op planning starts with a fundamental rule. The patient has to be fit for general anesthesia, but they also have to be fit for potential urgent conversion to a big, open operation. You must always have a plan B.
What are the main red flags you're looking for in the patient's history?
Coagulation disorders are particularly dangerous. Bleeding is just so much harder to control in that contained space. And second, any previous surgery or cancer treatment. You have to assume there will be adhesions.
So you need to set your threshold for converting to open surgery before you even start.
Absolutely. And remember, conversion is not a complication. It is the responsible exercise of sound surgical judgment.
What about body shape?
Morbid obesity requires longer instruments, but an extremely low BMI patient can also be tricky for port placement, especially with robotics where you need space between the arms.
And given how long these cases can be, what about thromboprophylaxis, DVT prevention?
It's routine and it's necessary because of the long operating times and the positions we use, like reverse Trendelenburg, which causes blood to pool in the legs.
Hmm.
So you're using low molecular weight heparin, stockings, and those pneumatic calf compressors throughout the case.
And what about basic prep? Has that changed with enhanced recovery protocols?
It has. In the old days, everyone got a urinary catheter and an NG tube. Now, with the ERS, we often omit those because they can slow down recovery. The key is just making sure the patient is fasted and emptied their bladder before you create the pneumoperitoneum.
The informed consent process must be a bit more complex here, too.
It is. You have to go beyond the standard risks. You have to explicitly tell the patient about the possibility of conversion to open and that it's a safety measure, not a failure. And you have to warn them about MAS-specific issues like shoulder tip pain and the rare but serious risks from the technology itself.
Let's move into the OR. The first big safety hurdle is actually getting inside, creating the pneumoperitoneum. How does that change based on the patient's history?
In a virgin abdomen with no scars, there are several safe techniques. But in redo surgery, where you expect adhesions, a cautious open technique for that first port is the way to go.
You actually cut down under direct vision.
You dissect down, you see yourself enter the peritoneal cavity, and you can gently check for any bowel stuck to the wall right where you're entering. It massively reduces the risk of an inadvertent visceral injury.
Okay, now let's dive into the most stressful scenario. Intraoperative bleeding. The number one reason for emergency conversion.
This is critical.
A significant vessel is hit. What is the immediate, clear action protocol for the entire team?
Step 1 is communication. Loud, clear, and immediate. You tell the anesthetist, the circulating nurse, everyone. The anesthetist needs to know blood loss is happening and conversion is on the table.
Step 2.
Immediate control. If you can't identify the vessel, just apply blunt pressure with an instrument or even the liver or another organ. Get suction and irrigation in there to try and see the source.
And what's the threshold for pulling the plug and converting?
It has to be low. If you can't identify the source after a very brief attempt, or if the patient's blood pressure starts to drop, you convert immediately. You do not struggle with an uncontrollable bleed in a contained space.
And if the robot is docked, the logistics of that are critical.
Absolutely critical. The bedside assistant has to be an expert in emergency undocking. That means disengaging the arms and moving that whole cart away in seconds. If you're compressing the bleed with a robotic arm, you might even leave that one arm in place while you get everything else ready for the open procedure.
What about more minor bleeding, say from an organ surface like the liver?
The liver capsule tears easily. The key there is to minimize excessive retraction. We'll often insert rolled gauze swabs and use those in a grasper to spread the pressure out. You can also use hemostatic agents like clot-promoting strips.
And if the bleeding is from a trocar site itself, say you hit the inferior epigastric artery.
That can be torrential. You can try pressure from the trocar first. If that doesn't work, you might have to put a big figure of 8 stitch through the full thickness of the abdominal wall. A low-tech trick is to insert a Foley catheter, inflate the balloon inside, and pull gentle traction on it to tamponade the vessel for 24 hours.
Finally, blood clots. They ruin the view. How do you get them out without losing your pneumoperitoneum?
Suction technique is key. You have to keep the suction tip below the fluid level or use it in short bursts, otherwise you'll lose your working space instantly. For big, dense clots, you have to physically get them out with a rolled sponge inserted through a large port.
Let's dedicate some serious time to electrosurgery, because inadvertent injuries here are so serious and often not recognized until days later.
The stats are sobering. Unrecognized electrosurgical injuries, usually bowel burns, happen in about 1 to 2 cases per 1,000. And there are 3 major ways this happens with a monopolar diathermy.
What's the first one?
Direct coupling. This is when your activated instrument touches another metal instrument, like a grasper. The current jumps to the second instrument and can cause a burn somewhere completely outside your field of view.
How do you prevent that?
You have to be meticulous. Always make sure the active tip is only touching the tissue you intend to treat.
Okay, second mechanism.
Insulation failure. The long shafts of these instruments are insulated. If that insulation gets a tiny nick or crack, current can leak out and burn whatever it touches. Again, potentially outside your view.
So the instruments have to be checked every single time.
Meticulously checked by the scrub team before they're ever used.
And the third, most complex one, is capacitive coupling.
This is a bit like static electricity. Charge can build up on an isolated metal object, like a metal trocar sleeve, even if the active instrument never touches it. That charge can then arc to the nearest loop of bowel. The safest way to prevent this is to use specialized monitoring systems, or better yet, just avoid monopolar energy in risky situations.
Which brings us to the safety anchor.
It has to be this. Bipolar diathermy is significantly safer and should be the preferred choice, especially in crowded anatomical areas. The current in bipolar is confined between the two tips of the instrument, which drastically limits the risk of these remote injuries.
Okay, now let's move to the post-op period. Recovery is generally rapid, but there are some specific issues with MAS.
Pain is usually low, but two symptoms are super common. First is nausea. Affects up to half of patients. It responds well to antiemetics, but it's made much worse by opiates, which we try to avoid.
And the second one is the symptom every patient needs to be warned about: shoulder tip pain.
It's a classic. It's not a shoulder injury. It's referred pain from the diaphragm being irritated by residual CO2 gas. It lasts a couple of days and simple painkillers help, but you have to warn the patient about it beforehand so they don't panic.
And avoiding opiates means you're relying on multimodal analgesia.
Absolutely. Nerve blocks are incredibly effective for thoracic cases. For abdominal cases, simple anti-inflammatories and paracetamol are usually enough. And we encourage patients to eat and drink just a few hours after surgery.
And that quick return to mobility is probably the single biggest advantage.
It's the engine of enhanced recovery. Patients are out of bed quickly. Because the wounds are small, moving is much less painful than after open surgery. This helps them clear their lungs and massively reduces the risk of chest infections. Discharge is then based purely on clinical signs: comfortable, passing urine, eating, and drinking.
All right, let's look to the future. The fusion of the digital world with the physical operating room. Let's start with augmented reality, or AR.
AR is all about overlaying computerized data onto the real surgical environment, and it's a direct solution to the loss of haptics, that sense of touch. A leading example is using immunofluorescence with ICG.
Indocyanine green, how does that work?
ICG is a harmless dye. You inject it, and when you illuminate it with near-infrared light, a special camera can see it glow. This lets the surgeon visualize blood flow or lymphatic drainage in real time, things that are completely invisible to the naked eye.
So you can visually confirm the blood supply to a piece of colon before you cut it.
Precisely. It helps you identify structures, and it's integrated into robotic systems like Da Vinci as the Firefly mode. You can just toggle between the normal view and this enhanced vascular map. It's like a superpower.
Another amazing AR application is in lung surgery with navigational bronchoscopy.
This is a fantastic hybrid approach. You take a pre-op CT scan and use it to create a 3D roadmap of the patient's bronchial tree. Then you overlay that digital map onto the live camera feed from the bronchoscope.
It's like a GPS to find tiny lung nodules.
Exactly. It guides you to these tiny, hard-to-reach lesions. You can make a biopsy, and if it's cancerous, you can place a tiny marker next to it. That marker then acts as a beacon for the surgeon during the subsequent VGS resection. It makes curative surgery possible for tumors that were previously impossible to find.
Let's pivot to the deep integration of artificial intelligence and robotics. How is AI helping right now?
At a basic level, AI can provide clinical decision support. It can analyze instrument movements and warn of deviations from optimal technique. Or it could detect and highlight structures at risk on the screen, like a nerve or a major vessel, acting as a tireless electronic co-pilot.
But the truly game-changing stuff is the move towards autonomous systems.
Supervised autonomy is the long-term goal. And the preclinical success has been stunning. There's a system called STAR, the Smart Tissue Autonomous Robot. It has already demonstrated objective superiority over human surgeons in performing complex bowel anastomosis in pigs.
That is definitive proof that for certain repetitive complex tasks, a robot can outperform a human.
Regardless of the human skill level, it can.
And the goal isn't just about movement, it's about real-time diagnosis during the operation.
And that's where the iKnife comes in. This technology analyzes the vapor that's created when an electrosurgical device cuts tissue. It uses mass spectrometry to read the metabolic signature of that smoke in real time.
And it can tell if the tissue is cancerous or not?
Instantly. Based on its chemical profile, this is immense. It allows the surgeon to verify that they have clear surgical margins during the operation, which could dramatically reduce the need for reoperation later on.
Finally, let's talk about the human element, training, and the ethical balance we're going to need.
The digital nature of all this is fantastic for training. High-fidelity simulation is proven to reduce the learning curve. You can practice until you're perfect in a completely risk-free environment. Robotic simulators are particularly good at this.
But there's a growing problem for new surgeons. The
Mhm.
lack of exposure to open surgery.
This is the critical balancing act. As good as MAS gets, new surgeons must maintain enough training and experience in open surgery so they are competent and comfortable converting a case when things go wrong. The core principles of good surgery exposure, retraction, hemostasis are universal.
Our deep dive into Chapter 10 has really traced this whole journey, from Kelling's crude experiments in 1901 to these hyper-precise 3D vision robots and AI-powered tools.
And the core narrative, really, is that persistent drive to overcome technical limitations, the 2D view, the fulcrum effect, the loss of haptics. But at the end of the day, these advancements are only valuable if they reinforce those fundamental surgical principles: safe access, good exposure, and meticulous hemostasis.
That journey from a rigid endoscope to a robotic wrist really brings us back to some timeless wisdom. Berkeley George Andrew Moynihan said it perfectly. The cleaner and gentler the act of operation, the less the patient suffers, the smoother and quicker his convalescence, the more exquisite his healed wound. Minimal access surgery is nothing less than the physical, technical realization of that principle.
A perfect way to put it.
Now, for you, the learner, we want to leave you with a provocative thought that builds on what we discussed about AI and autonomy. If we accept that a system like the STAR robot can reliably outperform a human surgeon at a complex task like an anastomosis, what does accountability look like when a complication arises during a robotically assisted surgery? Does the primary responsibility lie with the programmer who wrote the code, the manufacturer who built the machine, or the supervising surgeon who is sitting at the console? This is a fundamental legal and ethical question that your generation of surgeons will have to answer.